So good morning everyone, thanks for your patience. Welcome to this market briefing session on integrated care in New South Wales. My name's Rowan Hammett, I'm the Deputy Secretary for Strategy and Resources in the New South Wales Ministry of Health, and I'd like to start the session today by acknowledging the fact that we are meeting on the land of the Gadigal people of the Eora Nation, and to acknowledge their elders past and present, and to welcome those of you who are with us today. So I'm delighted to see how many people we've got involved in the briefing session today. There were some cynics who commented that when there's a pot of money then people turn up. So that's fine, we're happy to work with that. We have a number of speakers who our aim today is simply to inform you about the process and to allow you to ask questions. It is intended to be an interactive session and we will have plenty of time for questions at the end. We are a little bit challenged with the AV arrangements. We're videotaping the session so that those who can't be in the room today can see it. But the sound for the video session is only running through this microphone. So our question and answer session will have to be through the lectern rather than more broadly, but we can manage with that. So our other speakers today, Catherine Birchfield, who is our Director of Integrated Care in the Ministry and has been a major thought contributor and leader of the development of this program, and Catherine will be talking through the specifics of the application process. Ken Whelan, who runs our purchasing and performance division within the ministry and interacts on a daily basis with local health districts and other providers around the system, and Nigel Lyons, who's our Chief Executive Officer of the Agency for Clinical Innovation, who has been driving innovation in new models of care around our system. So what we want to cover today is the process and I guess an explanation of why we're doing this in the midst of challenging environment for health system funding, made substantially more challenging following the May 13 federal budget. New South Wales nevertheless is taking a conscious decision to step out into a space that has not traditionally been held by state health departments. So we'll try and explain that. We'll explain the process, how it interacts with the other programs that New South Wales are running, both through Ken's work and Nigel's work, and then plenty of time for questions. So you're not intended to be able to see all the details of this slide, but it's a pictorial representation of just some of the complexities of our health system. This actually depicts funding flows in the Australian health system from Commonwealth states, private providers, for-profit, not-for-profit, for individual consumers, a variety of stakeholders, local government included, and somewhere in that morass of arrows, we're meant to actually deliver healthcare that meets the needs of patients. This is an interactive session. How many of you actually have been a patient or had a near family member receiving healthcare in the last 12 months? Very good. Keep your hands up if you found the system easy to navigate. Excellent. We have the answer to integrated care sitting with Anne Brazel, who knows how it all works. But no, it is a challenging system for our system. When I asked our team to try and present a graphic representation of that, I said, listen, can you find me a picture of a little kid looking up at a set of road signs that are pointing in all sorts of different directions? And they couldn't do that. So I said, can you find an old man or something trying to do that? So they did a Google search and they typed in, well, I'm looking for an old man who's confused by healthcare, and they found So those of you who have your phones there and have switched them off, you can do that Google search, and Dr. Nigel Lyons is the confused man in our Australian healthcare system.
Internationally,
yeah, that's right. Some of you will be aware that New South Wales launched a new state health plan that sets the direction for particularly the next 3 years in our healthcare system, but with a trajectory looking over 10 years. It points to three key directions that New South Wales Health is taking our system. First of all, keeping people healthy. population health, prevention, making sure that we can keep our communities as well as they can for as long as they can. Direction 2 is making sure that we can provide world-class clinical care within what has traditionally been our core business, our hospitals, our highly performing system, indeed a system that performs comparatively better than almost any healthcare system in the world. And a new direction for New South Wales, delivering truly integrated care. So integrated care is the third and indeed the only new significant priority that has been added to the State Health Plan, and it's of that level of importance to our system. Minister Skinner announced the integrated care funding package, and we need to be mindful that within a $19 billion budget, $120 million investment in integrated care is not going to be able to solve every problem of integration overnight. But it is nevertheless within a growth funding envelope. Every year for the last few years, New South Wales Health has had an annual budget growth of about 5%, which means that there are new dollars to buy new activity within our hospitals and also to fund strategic initiatives such as this that are aiming to deliver long-term change to our system. This program builds on significant other pieces of work that have been going for many years. We can't pretend for a second that this is, an original idea. This isn't something that isn't being talked about in other systems around the world. Indeed, it is the fundamental challenge that most health systems in the world are trying to grapple with, how we actually integrate our services to deliver the best possible outcomes. And New South Wales Health and its partners through Medicare Locals and the Commonwealth at times, our NGOs and indeed for-profit providers have been working with us on a number of programs for many years. What we want out of the integrated care strategy can be summarised in these objectives. I'm not going to read them word for word, but fundamentally we're trying to deliver new ways of providing care to get better outcomes, particularly where there is fragmentation. And often that fragmentation occurs at the interface between hospital and primary and community care. So there's a real focus on that interface in the community. We want to make sure that we're actually organising care to meet the needs of certain groups of patients, those patients that are at greatest risk of facing fragmentation, and many of you will have views about that. Traditionally, health services around the world have largely been organised around the needs of healthcare providers and the healthcare system itself. And while most of us would sign up to language that says we're interested in patient-centred care, there is a risk that that becomes simply a nice motherhood and apple pie phrase without specifically challenging us to redesign the very way our system is structured and delivered, to make sure that the structures and the processes that we put in place are designed specifically around those needs of the patient rather than the providers or the system. And so that's one of the key objectives of this piece of work. We really want structural design around patient needs. We also want to make sure that we can leverage all the available service providers that are out there in our community, both in metropolitan regions and particularly in rural regions. And some of you will be aware that this funding is funding demonstration projects in 3 local health districts, one of which is the Western New South Wales Local Health District, which is a rural health district, and we are specifically looking at grappling with the needs of integration in rural settings through that process, and are very interested in developing new models to deal with the challenges of healthcare in the 21st century in small rural communities. We do want to improve the flow of information between hospitals, specialist community and primary healthcare providers. Why? Because there's a whole lot of waste that occurs because there isn't adequate information flow between those providers. Lots of duplication of testing, both pathology, radiology, lots of inappropriate, at times, care because people aren't aware of what's going on. We're also interested in exploring new ways of working with other parts of government, including the Commonwealth, and actively interested in partnering with organisations like Family and Community Services, but many other organisations across government, and indeed other partners, the not-for-profit sector, the private sector, and I'm delighted there are so many of you from those sectors in this room today. And lastly, we want to make sure that those people who are best cared for out in the community actually receive that care in the community. Most of us are well aware that were there appropriate community services available to treat a whole variety of conditions, the care would be better provided there. Hospitals, unfortunately, are dangerous places. You have a significant chance of running into strife if you spend too much time in hospital, and I'm a physician by training and would recommend strongly that all of you avoid hospitals for as much of your life as you possibly can. But there are times when you need care, and if we can give you care in the community and keep you out of hospital, that is a better situation than it currently is. How are we going to measure success in this? Well, a whole lot of things, and there are evaluation frameworks in development for the demonstrator sites, and we would expect evaluation and demonstration of improvement within projects funded through this Innovation Fund. Things such as your patients, our patients, telling us that they can navigate the system more easily. So if we held this briefing again in a year's time or 2 years' time or 3 years' time, Anne wouldn't be the only one putting up her hand saying that the system was easy to navigate. We want to make sure that patients have a different and a better experience of healthcare, and with that, better health outcomes. We want to see reduced waiting times for patients as they navigate the system, more people cared for in the community, and specifically a reduction in avoidable hospitalisations for conditions that are better treated elsewhere. And we do want to make sure that we see better information sharing and a consequent reduction in unnecessary or inappropriate tests that may be duplicated. So the 120 million investment from Minister Skinner is in 3 tranches. We have, as I said, 3 demonstrator local health districts who are looking to develop quite deep system change within their environment, and they will be funded for a 3-year period provided that they deliver and measurably deliver on improvements in care. Should they not deliver, then their funding will be terminated. We are also investing in a number of what we call statewide enablers, things that we believe the system needs to allow it to integrate better. Things like risk stratification tools that understand who are the patients most at risk of fragmented care and how can we identify them and work with them to make sure that their care is fully integrated. Things like patient-reported outcomes measures. And those of you who aren't aware of PROMs, it's worth looking up. It guides care very much based on what the needs of patients are, not just what the providers are. We're investing in real-time patient feedback, where patients can tell us their experience of care and allow us as a system to react in real time to improve that. We are extending a system in New South Wales called HealthyNet, which will allow every hospital, every individual who is treated within the New South Wales health system to be linked up by a unique identifier that will pull together whether you're born in one hospital, treated in another, and look to die in another. We'll be able to link that system and link it to the personally controlled electronic health record, which will allow the potential for transmission between primary and acute care. So those are the sorts of statewide enablers. And lastly, and importantly, we are actively looking for breakthrough, innovative ideas from local health districts and their partners who really have ideas about how they can better integrate in their own environment. Because, I jokingly said Anne's the person with all the answers. There isn't anyone with all the answers about how to integrate health systems, nowhere in the world. And we've looked around the world, and there are models that have been applied in different parts of the world, some successfully, some not so successfully. And it is early days in terms of the development of that. But what we're hoping to do is seed models that will work across our system with a view to potentially scaling them at an appropriate time. Now, the answers are going to be very different about how you integrate care in central Sydney compared to Broken Hill. And the solutions that you find will be very different according to your local environment. And so New South Wales Health has made a conscious decision not to come up with a model of integrated care that we are seeking to impose on the system. We're actually asking you for the innovation, for the solutions, because you're on the ground, you know where the fragmentation is and the disintegration is, and we want you to work to develop the solutions with us. So, what is this? This is actually a seed fund that will seek to support innovative ideas at the local level. We're proposing that funding may be provided for up to 3 years, should the specific innovation require that it's performance dependent, that you bring skin to the game. Now, Carrie Shulman, as we were walking, had said, the first question they're going to get is how much money there is. And I said, well, the first question they're going to get is how much money are you bringing? Because we really do expect local health districts to invest some of their resources and their partners to invest some of their resources into this integration exercise. The New South Wales health system clearly is only responsible for a certain part of the complexity of the Australian healthcare landscape. We do not have the fiscal ability to take over the whole of healthcare in this state. In fact, New South Wales Health only provides about 43% of the total healthcare spend in this state. The other 57% is provided by the Commonwealth and by you. And we need to leverage that. So we are asking, we're going to seed stuff, we do want to see what the partners are going to bring and how we can leverage that investment. The funding may be used to cover direct project costs, and we need to make clear that we're not interested in this funding, in funding infrastructure costs or in funding positions that have already been funded through existing programs. This is meant to be new work, innovative work. We're proposing that the funding will be directed to the local health district and specialty health networks. There are 15 of those in our system who aren't demonstrators, the 3 LHD demonstrators, but we are requiring that the LHDs in seeking that funding and managing that funding will have partners working with them, and that will be a requirement of their applications. Ultimately, what we're interested in doing is not just funding a pilot program. We want to fund something that's going to last, that is transformative, that is sustainable, that is scalable. So if you in the room are interested in seeking funding to do a little pilot, that you want to see if something works, but really that's the end of it in a couple of years, this isn't the funding pool for you. Okay, we are looking for transformative and sustainable change within our system. So there are a number of principles: collaboration, partnership, true innovation. We have selection criteria that Catherine will take you through very shortly. We are going to measure performance, and funding will be contingent on successful performance. Having said that, inevitably innovation is associated with risks of failure, and we understand that, and we understand that that's the nature of some of these projects. So what is innovation? Well, innovation is not just improvement. We hope that it is improvement, but it's not just improvement. This isn't just a matter of tinkering your existing processes and hoping they perform a little bit better. It's not doing what you've traditionally done and extending your existing programs with this money. And it's not per se incremental change. It's about far more than that. It's change at a system level. It's doing something that is fundamentally different to the way you've done it. I've talked about how we want structural and process change built around the needs of patients. And it is transformative, a game changer. We have talked about how we are looking to measure it. Fundamentally, better patient experience, improved health outcomes, less waste. And I'm now going to get Catherine to take you through the specifics of the application process, timeline, selection criteria, so that you're all aware of how to access the funds.
Good morning, everyone. Rowan's wisely left the safe part of the presentation to me. I'd just like to start by echoing Rowan in thanking you all for coming today. I know that many people in this room have been waiting quite some time to hear what we're planning to do with this fund, and I thank you for your patience. It's really fantastic to see so many people here from across the system and across industry, and I'm looking forward to seeing some new and innovative partnerships bearing fruit as a result of today. So in terms of the application process and timeline for our Planning and Innovation Fund, we have an application template that's available on the New South Wales Health e-tendering website, but you can also contact the Integrated Care Branch. Where's Caroline? Caroline Curtin, for those of you who don't know her, is up in the back there. She's a program director for this program, and so she's always there as a point of call, as is anyone else in the team, including myself. We have the briefing today, and then an application process which is open until the 3rd of October. Following that, we'll be going through an assessment process for during October and November, and then we'll have all applicants advised of the outcomes by December this year. The selection process will be led by a selection committee, which includes people from the Integrated Care Branch, the Whole of Hospital Program, and the Agency for Clinical Innovation. There'll be an initial assessment of the proposals that are submitted to us that are considered by the selection committee, which will lead to a shortlist. And at that point, there may be some requests for presentations of proposals to provide further clarification or participate in a readiness assessment to help understand how deliverable a proposal may be. The committee will make recommendations around the proposals and those that we prioritise for funding. And as I said, the applicants will be notified by December. We'll be then negotiating a funding agreement with the successful project applicants and agreeing the amount of funding that is provided by the ministry. There's a lot of information provided on the selection criteria in the guidance that, if you haven't seen, is a hard copy of that guidance here today. I'll just quickly run through the 5 selection criteria that we'll be using to assess the proposals against. They're innovation and policy alignment, sustainability, scalability and transferability criteria, local partnerships and the contributions from those partners, program benefits and outcomes, and then finally project design and feasibility. So going into a bit more detail on those, the innovation criteria is really about alignment with the integrated care strategy as a first point, and then an assessment of whether a proposal is locally innovative versus incremental improvement or a slight extension of something that's already in place. And the proposal should really demonstrate a focus on patients. When we're looking at sustainability and transferability, we're looking at proposals that can continue beyond the funding period and be embedded in a system, but that also have the potential to be scaled and transferred to other parts of the system. There's a little bit of a balance here because we do want to support initiatives in rural areas in particular and have a balance between metro, regional and rural. And we recognise that there are some parts of the system, Far West for example, where it might be difficult to produce something that's transferable because it's a particularly unique environment. And we don't want to rule that out, but we do want to have a balance between that and sustainability, transferability and scalability. Oops, going the wrong way now. The third criteria around partnerships, all LHD applicants will need to demonstrate that they're collaborating with local primary care organisations, with NGOs and the private sector as relevant, as appropriate. They'll also need to demonstrate what that collaboration and governance looks like for the proposal and how communication's going to work. And finally, to outline the financial commitment that the partners are bringing and what that looks like. All of the proposals should clearly define the target population and they should address the appropriate performance metrics that are relevant to the initiative and that relate back to our objectives for the integrated care strategy. And there should also be some description about the likely quantum of benefits versus the costs of the initiative, which is really part of the sustainability discussion also. Finally, we'll be looking at feasibility, so assessing the likelihood of the initiative achieving its stated objectives. By the way, those objectives do need to be clearly stated and measurable. Program management elements should be outlined, so it should be clear how the work is going to be undertaken, timelines, plans, risk mitigation, budgets, staffing, etc. And there's a template that we have developed. The budget for the proposal should be provided using that template. So, before we move to question and answer, I'd like to hand over to Ken Whelan, who is the Deputy Secretary of System Purchasing and Performance with the Ministry. Ken's, amongst other things, Ken has been spearheading some really fantastic and highly successful work across the system to better integrate care within our hospitals through the whole of hospital program. So Ken is going to talk about that program and some of the other links between that work, integrated care program and wider purchasing and performance. He'll then hand over to Dr. Nigel Lyons, who's going to talk about some of the critical and complementary work that the ACI is doing in this area. Thanks, Ken.
Thanks, Catherine. Just want to talk a little bit about the whole of hospital program. And for those that are here from the LHDs, what I'm about to say won't be news to you, but I think it's important for those other parties who are thinking about putting in a proposal that you at least have an understanding of what we're trying to achieve within the whole of hospital program. Whole of hospital firstly started as a result of New South Wales performance in the Commonwealth metric of NEAT, which is access, 4-hour access times within the emergency department. I note even now the Commonwealth even have decided that they're not that interested in NEAT. Well, they're not interested in paying for it anyway. So once we got into that, we thought this is about the emergency department, because that's what we often hear. When in actual fact, once we started looking at it, the emergency department performance in access times for patients is actually pretty good across most of our hospitals. But when you look at those patients who have been seen in the emergency department, and let's be clear, we have 2.4 million presentations a year through our emergency departments in New South Wales. That's a big metric. Those patients where the decision is made to admit, that's where we tend to fall over. So if we're trying to get to 75% dealt with in 4 hours within the emergency departments, often it's up in the late 60s, early 70s. When you actually look at those patients where the decision has been made to admit, whether they're admitted within 4 hours, it's sort of up in the 40%, 50%. The worst performer, I think at one point, was 10%. So that was probably not a good hospital to go to if you needed to be admitted. Fortunately, they've improved significantly. Why? Because we've put a strategy in place which looks at integrated care within the concrete of our hospitals. So how do we better integrate the systems that we've got within our hospitals to ensure that the patients can flow through the hospitals and access the care they need within those hospitals in a timely fashion. From December 2012 to June 2014, there's been a 15% improvement across the state. 15% doesn't sound very much, really, does it? That's 350,000 people, which I think is pretty impressive. So part of the strategy, how we've done it, is actually facilitate change by working with our partners, ACI, CEC, and our LHDs, to actually understand those hospitals where the patient journey works really well. Look at those hospitals that are perhaps struggling somewhat and try and leverage that learning across the system. It's not about one size fits all. It's a very inclusive process. Clinicians are heavily involved in decision making. We've still got a lot of work to do. The journey's really just begun. But the other thing, which won't be a surprise to any of you, that we started thinking about was, so as we go on this journey of better managing care within our hospital system, the big game in town in terms of sustainability is what we do either before the patient gets to hospital to stop the patient coming at all, or the person coming at all, and then for those patients who do need to come in for a short stay in hospital and they go home again, how do we better support those people within the community in which they choose to live? So we talked a lot about morphing whole of hospital into whole of system. We don't need to do that now because integrated care and you people are going to do that for us. I think from my point of view, what I would be looking for as part of whole of hospital is a couple of things. Firstly, within this program, how any proposal links with the work that's going on within our hospitals. I think that's really important. And certainly my whole of hospital team, if anybody is putting a proposal together and wants more detail around what we're doing in a particular community, I'm very happy to make the team available to actually help inform that. And secondly, and this is aimed as much as LHDs as anything else, we don't want more of the same. Like, there's a lot, as Rowan said, we've got a $19 billion system, so we spend a whole lot of money every day, and that's only, 43% of the total health spend in New South Wales. And we throw money at pilots. As somebody said recently at something I was at, in the system we've got more pilots than Qantas. And we don't want that. We've got a lot of that. And there's a lot of that sort of innovation, day-to-day innovation happening. This is a real opportunity where there's some real money that's quarantined and put aside that says, hey, we want you to think out of the box. We want you to embrace your partners, and we want you to come back to us with a proposal that you feel will actually be a significant game changer. From the whole of hospital point of view, we're very happy to work with you to make that a reality. Because the one thing that is absolutely clear, when you look at the volumes and what's happening within our health system, we cannot continue to do what we are currently doing. We have to think about doing it differently, and we believe that many people in this room will have the answer to that. Nigel.
Thanks, Ken. Thanks for the opportunity to talk with you. It's nice to see that Rowan finally got one back this morning. It's been a long time coming, Rowan. A great opportunity just to share with you some of the thoughts about how we can be involved from the ACI point of view. And I think we've been doing some work in this space for some time, number one. Number two, we've been working with the demonstrator LHDs to think about what their integrated care proposals will contain. But thirdly, I think we have some experience around this area, and we're very happy to work with you as you think about what you might be involved in putting forward and to actually help you to develop those proposals. So I'm going to share with you some of the things that we've been involved in. So the first thing is there's lots of work underway currently. In Hunter, New England, for a number of years now, Health Pathways has been in place. They've got some quite good experience now around developing pathways in partnership with other providers. We're involved in evaluating what's been happening in Hunter, New England. There's a two-phase evaluation. The first has been qualitative, which we've got available, and the second will be a more quantitative evaluation of the impact of Health Pathways there. That will be published in the next little while. We also went through a process of thinking about how we could support implementation of pathways in other environments. So there are 3 other sites that we're working with who we're supporting the implementation of Health Pathways, and will be involved in evaluating the impact. And you can see there Inner Western Sydney LHD, Went Western, Western Sydney, and the Central Coast Medicare Local and LHD. In particular, what we want to understand is, given the Canterbury experience in New Zealand, is that transferable to our environment, to our context? Because we all know that around the world where integration is working, it's not always transferable to other environments. We're also conscious that health pathways are not the only way to develop pathways for care, and we're also working with South East Sydney Medicare Local to look at what they're doing around the map of medicine, and we'll use a similar evaluation approach to look at the impacts that use of that system will have as well. There's no doubt in the early phase of the evaluation we're hearing very positively about the benefits, particularly from the providers around coming together and mapping out how they should provide care and improve the experience for patients and linking what they do. In fact, we're hearing that there are discussions that have never been had before between providers, which are really critical. But we're really conscious also that pathways is only one component of how we can improve ambulatory care. So how does that fit into the overall efforts around integration? We've done work in the musculoskeletal area. There's been some fantastic work done around osteoporotic refracture prevention, osteoarthritis care models, which were predominantly out of the hospital system to start with. What we're now doing is to start to think about how can we provide those models in a primary care setting, and how we can get better integration across the boundaries, or the historical boundaries. And we're doing work in 3 sites, Mid-North Coast, Northern Sydney and Murrumbidgee, to see whether we can actually transfer those models into a primary care setting. Central Coast have embarked on a whole transformation about how they provide community health, and we've been partnering with them from the outset to look at what the impacts of that might be, and also a built-in an evaluation methodology so we can start to see, as they make those changes, what differences it have, and are those learnings able to be applied elsewhere. Chronic disease management, we've been involved in the Connecting Care program now for many years and have experience about the challenges of implementing those changes. And we're conscious that across the system there have been different approaches in different places. The level of involvement of general practice in that model varies around the state, and the way it's been applied varies depending on the geography, the service configuration, partner relationships and so forth. But we've got a lot of experience and tools that can help support assessment of how you might get better integration for that group of people. There are self-assessment tools, patient and care experience tools. We're revising our approach to chronic care rehabilitation to ensure that the toolkit support and relate to the chronic disease management programs. And we're also very conscious that we need to think about particular groups who need a focus, and our Aboriginal communities. We're working with the AH and MRC to think about how we can actually develop a framework particularly targeted to support better care for Aboriginal people in the context of their chronic disease journeys as well. Pain plan is another area where we've had some experience now in looking at a totally different way to provide a service at a system level, and with a real focus around self-management of patients and tools to support their self-management that are web-based. That's been extraordinarily successful. The hit rate to those tools has been extraordinarily high, but what it demonstrates is that if you set up a system which is around self-management, linking with primary care and backed up with specialist services and integrate that holistically, you can significantly improve care for groups of patients, and we see that as a great model that might be built on in other areas. We're also looking at what's going on with older people and their complex health needs, a particularly challenging group, an area that needs significant focus. So we've developed a framework for older people with complex health needs, and we're partnering with the Aged Health Network in our organisation, but with a number of Medicare locals and the residential aged care sector about how we start to implement those models across the system as well. And there are opportunities to think about in the context of that framework. And another piece that we've undertaken, I think would be particularly useful as well at the local level, is to start to map out the care and look at what the components of care are, particularly in your own context. Where do you have services? How do they relate to other services? What does it demonstrate in terms of duplications, but also gaps in where care is currently provided? And this mapping process might give you an opportunity to identify where are the places you might start in the projects that you might consider for your communities and your populations. So very worthwhile process to undertake. And finally, we've got a lot of tools around developing models of care, redesign and implementation methodology and tools to support that. They're all available within our organisation. We've established a small health economics team that can help assist with assessment of activity and cost and how you might apply your resources differently. And we've got a patient experience and consumer engagement team who are also very actively involved in developing tools and supports for how you might measure those benefits that you're seeking to achieve as you move into your project definition. We're also conscious of the need to share information and share resources. We have a portal that we've established with the CEC, which has got a lot of information about programs and projects that we both are supporting across the system. And in the next little while, we'll be launching the Innovation Exchange, which is a revamping of the old Archie website, but is now going to incorporate projects and programs that have come out of the clinical leadership program at CEC, out of the HETI programs, out of our own work with Clinical Redesign School. And we'll have an enormous amount of information about work that's been undertaken across the system, what people have learned, the successes they've had, but also where there are opportunities to do things better and differently, and that will be launched in the next month or so. So in summary, I mean, we're very excited about the opportunities. We see ourselves as a resource that is here to support the change process with some knowledge and expertise, but also very keen to work with you to learn more about what works and what doesn't work and share those across our system and more broadly across the country. So thanks for the opportunity.
All right, thanks very much. And I'd like to reinforce what Nigel was saying about the importance of understanding through potentially things like mapping your processes, what the right part of your system to tackle is in applying for these funds. We know that across the state, for instance, 1% of people who attend our hospitals use about 30% of our resources. So that's 16,000 individuals spending about $4 billion a year in healthcare. We know that in one of our demonstrator sites, 2,000 individuals in that local health district expend 50% of the local health district budget. Now, to my mind, those are markers of fragmentation. Those are markers of individuals who need a more holistic approach to care so that their care doesn't have to be, as a default, within a hospital. So if you want to know, all the local health districts have access to an activity-based management portal that has detailed information about every single patient that is treated in this state. And analysis of information there and through pieces of work done by the clinical redesign team, by the whole of hospital team, should point you and your partners into which parts of your district work an approach to integration is going to deliver the best return on investment for you. So I'd encourage you to do that.